Hello, everybody. Welcome to another live stream focusing on imaging of X-rays. This is our summer live stream. We will today focus on certain tumors. And we also have a special guest from Turkey, which I will introduce later on. My name is Dr. Kai. I'm a radiologist in Berlin. And we are collecting cases and working very intensely with the BerlinCaseViewer app in order to present cases, to create learning content. And today it's my pleasure to have you here as guests. We will have some interaction about tumor cases. We might have also some differential diagnoses. We will discuss very intensely about the cases, and of course we also have cases prepared for you to try it yourself on your devices, so you can click along while we present the cases, and we also might have the occasional multiple choice question that we would like you to answer. So right now, I see that some of you are already online. That's nice. It's always nice when people are there at the beginning of the session. So if you are on LinkedIn or YouTube and are able to comment, maybe you write a comment where you are now, so we know if we have guests from outside of Germany, maybe even from outside of Europe. That would be very worthwhile to learn. So while you are commenting and search the comment box, I will share the first case, and we'll also share the case viewing platform. So some of you might be already familiar with the case viewer. So here is my screen. I will also share how it looks. I will share it in the chat box soon, the link, so you can click it. And bcv.app/. So, okay, so this is the link. I'm sending it. I cannot send to all platforms, so I will also need to place it down here. So that is the link that you can use, bcv.app/tumor25. That's our link today to access the cases. And we have also a QR code. So once you, if you work on a laptop right now and watch the stream and want to work along the cases, then that's of course something that you can do with a QR code that I will bring you right now. Hold on, and I will download it from here. So here we have like media, that's delete. So if you now scan the QR code in the corner, that's over here, then you can access this link, so you do not need to type it. So do we have any responses? Oh yes, we have nice responses. We have somebody from United Arab Emirates coming. We have somebody from Singapore joining in. So it's very nice. And so that's very good. So if more of you would like to comment, that would be very nice. Otherwise, please use the platform. I will also now share the respective window. So this is how it looks. This is our welcome screen that you see after you have clicked the link. And what you do is you click the blue button, Join Now. You can enter your name and email if you want, but you do not have to. If you do it, you can comment on the cases. So if you join here, you will be inside the case collection. And here we have 6 cases prepared for today's session. And usually it works like this, that you enter the case, then you see some of the images. Up here we have the information button, the medical history of the case. So in this case, it's a 60-year-old female, and you can read about the history of the patient. And while doing this, you can also do the interpretation. You can enlarge the images. You can use the split screen button in order to see both images together. So you can have a side-by-side comparison. And also what you can do is if you click on this speech bubble here, you can place a pin on certain areas where you can ask about specific findings. So for instance, if you're not sure how you would call this, you can confirm the pin position here and ask what is that, and then this comment will show up on our side, and so we know exactly what is your concern about the case. So this is already our first case, and we have no, you don't see actually what I did. That's not so good. So you missed all of that, what I just demonstrated. So we'll do it again in order to show you what's going on. So you click the, first I share my screen, and now you see the welcome page. You enter your name and email, or you don't. It does not matter. You click Join Now, then you are here at the cases, and then you can open the case collection. You have 6 cases. You are then able to open the case to read the medical history. You can split screen and look here to go to see what's going on. And if you want to ask specific questions, then you can use the speech bubble here. You get a blue pin that you can place somewhere, place it on the X-ray, confirm the position here, and then ask a question, what is this, or need more info. Okay, and that is then showing up on our side. Okay, so sorry that you missed this in the first try. Okay, let's go into details. We have here a 16-year-old female, and she twisted her ankle during a sports lesson at school. And so she was referred to the family doctor, and family doctor referred to the surgical department. An X-ray was taken, and here we have this X-ray showing up. That means we have now 2 planes. It's an ankle X-ray that's focusing on the joint space of the ankle joint, the tibio-talar joint, and so there's no trauma here, so there's no malalignment of the joints, but we have this lesion. So the question is, how can we characterize this lesion? What type of lesion is that? And therefore we have this multiple choice question over here. And you would now, if you are on the platform, would be able to decide which of the following is the most likely diagnosis. You can, I've given you 5 different options, and we will see if we have results coming in from you. And I'm curious to know. We have already 10 results, so that's very interesting. That means a lot of people are now on the platform. That's very nice. So let me change my screen to the results section. And I need to share another browser. So you will get this. I don't stage here. So that's now even 12 person did answer, and we can now work nicely with this case. So I'm curious on what's going on. We also have one new comment, so we will go through all of this. So we have 91% going for the correct answer, non-ossifying fibroma, and we have also one participant answering for simple bone cyst. We have nobody here saying it's a malignant bone lesion, and that's very nice. And I will go into the classification of bone tumors shortly. Also looking at these comments, we have Carlos from Spain, and he wants to know about the difference between NOF and the cortical desmoids. Yeah, that's something we need to find out. Okay, so we have here the lesion. Let's enlarge this a bit, and as you see, it is in the cortex. So that's the cortex. That's the spongious bone, and the lesion is arising from the cortex. It has a very thick wall and a very thick delineation and a border to the normal spongious bone, and we see a very thin line covering the lesion. So it's a very thin line of cortex still there. So we see no ill-defined margin. Ill-defined margin would be a dangerous sign, as this would be a sign for malignant bone growth. And also there is no calcification inside. That's very important for the diagnosis of fibrous bone lesions, because in chondroid bone lesions, for instance, in chondroma or also malignant chondral lesions, we would have calcifications inside the lesion, and this is not present here. In the second plane, we also see the clear delineation of the bone lesion. So we have a sharp border in all parts, and that's very important, because what many of you know, we have the Ludwig classification that we use to classify lytic bone lesions, and we distinguish between those that are most probable benign, that's especially 1A and 1B. And with 1C, it's already a borderline situation, but lesions 2 and 3 are showing us very intense bone growth, very fast bone growth, and are associated with malignant bone lesions. So in grade 1 and types A and B, we have a very localized bone lesion with no cortical reaction, with an intact cortex, and that's usually the kind for enchondroma, for non-ossifying fibroma, for bone cysts, with a disruption of the cortex as it is defined in Ludwig grade 1C. That's already a dangerous sign, because disruption of the cortex is always something you would need to do further imaging tests in order to see if there's growth outside of the bone, or if there's some invasion of soft tissues surrounding it. The higher grades are defined between the localized destruction with ill-defined margin and cortical destruction, and the more like permeative growth. That means in the grade 3 lesions, you cannot really say where the lesion is ending, because there's no end visible, and it's like an invisible infiltration of the entire bone. So what did Dr. Ludwig not describe? He did not describe the classification of sclerotic bone lesions. So while we have some idea on how is sharply defined, ill-defined, distinguishing between benign and malignant bone lesions to a certain extent, the Ludwig classification is only for lytic bone lesions, and for sclerotic bone lesions is not described so far. Okay, so here it is a non-ossifying fibroma, It's a non-ossifying fibroma. Sometimes this lesion is also called fibrous cortical defect. That is more or less dependent on a little bit on the size, but also on the nomenclature used in the local region. I compiled some key imaging findings for you to remember. It is a fibro-osseous lesion, so that's the benign lesion. It belongs to the tumor-like lesions. So in the WHO classification of bone tumors, which is adapted, was adapted recently in 2020. Non-ossifying fibromas are regarded as tumor-like lesions. So that's not really a tumor. It's not a benign tumor, not malignant. It's a tumor-like lesion. So it's a lesion that also has some shape variance during the age of that lesion. That means this lesion, and that's given lower down here, this lesion can spontaneously go away. So this defect here, this is now a 16-year-old girl. When she is maybe 24, this might be completely have disappeared, and we see a normal distal tibia in these patients. So what else do we have? We have we need to know that usually these lesions are small and do not require any follow-up. So that's really important. This is a so-called leave me alone lesion. If you see it, it is clear it's a non-ossifying fibroma. You can call it also fibrous cortical defect, depending on which nomenclature you are using. There are some people distinguishing between small lesions that are the fibrous cortical defect and the larger lesions, which are the NOF. But I think more or less it's the same type of tissue, same type of lesion, and non-ossifying fibroma is the current nomenclature, at least in the English literature. And it affects children and adolescents. Most commonly between, 4 is quite young, maybe more like 10 to 20, and it is going away over time. So that is basically the conclusion here, and I think it's now a good moment to stop the screen sharing and to welcome our guest today from Turkey, and our guest is Özgür Tosun from Izmir, from the nice city of Izmir in Turkey at the Mediterranean coast. Hello, Özgür. Nice to have you here.
Hi, Dr. Okay. It's a great pleasure to be here with you. I would like to express my thanks to you for inviting me for the program. I am Dr. Özgür Tosun, a musculoskeletal radiologist from Turkey with a 25 years of experience. I am currently working at İzmir Kerpiç Çelebi University, Atatürk Education and Research Hospital, where I also actively involved in mentoring and training brilliant, hardworking radiology residents. I will be share 2 musculoskeletal case in this platform, highlighting the importance of the X-ray for the diagnosis.
And I can say, I know Özgür from his social media activities. He's a very well experienced professor of radiology. He has a vast collection of cases. He is very active mainly on Instagram, and he also has his own website with cases, and the webpage is Radiology Bone Muscle Joint. And there's also an Instagram channel of the similar name, and you see that there's a lot of cases collected in his library, and they are all very well described. So if you want to learn, you can use his site as a reference. So let us share your screen, Özgür, and I will give you the podium to present your case and to give us a bit background about what you have prepared for us today.
Can you see my screen?
Yes.
Yes. Okay. Thanks, Dr. Kai, again. My first case, 22 years old, 22 years old male patient presented with a right knee pain after minor trauma. And he was otherwise healthy, no systemic illness. His labs were normal, no medication, and 2 plain knee X-ray were taken. And this is the lateral plane knee X-ray. This is the anterior posterior X-ray. And you can notice the knee splint around the knee joint. There is no evidence of fracture or dislocation that can be related with knee trauma. Bone alignments looks normal, and also joint alignments looks normal. There is no dislocation. In the evolution of the soft tissue, there is no abnormality within the soft tissue. There is no abnormality. There is no calcification within the soft tissue. There is no air within the soft tissue. And this is the shadowing of patella in anterior posterior X-ray. This is the and there are 2 lesions. One is located in the distal diaphysis of the femur, and the other one, which is more dense, sclerotic lesion, located in the proximal metaphysis of the tibia. It has a little bit irregular borders. It is located near to the posterior cortex. I would to ask you, based on the X-ray, how would you classify the lesion? Is it benign lesion? Is it malignant lesion? When you evaluate the bone lesion, you should always firstly consider the age of the patient. You should always consider the age of the patient to determine if it is benign or malignant. And I am waiting your answers. How do you classify
So we have
the lesion?
already 13 answers, so you can show the answer in the QA button.
Okay.
You can go to the QA and show the answers. You see 60% for benign and 40% for malignant.
And I think there is no comments.
No comments.
No comments. Yes, I can also classify this lesion is benign lesion because considering the age, because as you all know, before the 13 years of age, mostly benign lesions are seen in the bones. And there is no soft tissue extension, there is no periosteal reaction, and there is no alarming sign related with the lesion of the patient. And patient was discharged with symptomatic treatment. Advised to return back if the symptoms persist or worsen. I'm continuing.
And they did persist. This is a follow-up.
Yes. And 10 months later, patient came back with a night pain that interrupts the sleep. As you know, as you all know, when a night pain interrupts the sleep, is a classical red flag sign that needs further investigation. And this is the follow-up X-ray. And the quality of the X-ray is poor when compared with the initial one, but you can see the striking progression of the lesion. Now, I am asking again, how would you classify the lesion now? Is it benign lesion or malignant lesion. Based on the follow-up radiograph showing an progressing lesion.
So while people are voting, I think it's a very interesting approach to do lateral X-rays with the two knees in one film. I've never seen it, but I think it's very inventive of the radiographer to have these two lateral knees together.
Yes.
Do you see it a lot like this?
Sorry?
Do you see the X-ray a lot like this with two laterals in one film?
No. Depends on the technician. Sometimes we can facing the X-ray like this, but generally it is not. It is not like this.
Okay. So let's look at the
right.
questions. At the results. Yes.
And I think.
So in question 2, 100% malignant.
100% malignant. I agree with the participants. Now, because of the patient reflux symptom and the progression of the striking progression of the lesion, it should be classified as malignant.
So can you help us why so we have now the follow-up with 10 months, so it's very very fast. Can you help us? So if you only see the follow-up, the first X-ray is not available. Can you enlarge a bit the lateral or the AP view, so with the plus, in order to give us some hint on why this is now malignant even without the follow-up?
The progression is one of the findings that may indicate the malignancy, and the lesion contain ossified matrix, which suggests the ossifying osteogenic tumors. And on lateral X-ray, there's a suspicious soft tissue extension. As you all know, when a bone lesion extends into the soft tissue, it should be considered as malignant until proven otherwise. And the lesion extends to the epiphysis, from metaphysis to the epiphysis and diaphysis. And due to the patient reflux symptom and the aggressive feature of the lesion, MRI was recommended for the patient. I can continue with the MRI.
Yes, please. Yes, please.
Yes. And this is coronary plane images. This is still images, and this is T1 weighted images. The signal intensity of the lesion hypointense in both sequences. Hypointense in both sequences. This is coronary plane images. You can evaluate the borders of the bone tumor in T1 weighted sequences. Clearly define the borders of the lesions in T1 weighted sequences. This is fatty hyperintense normal bone marrow signal. This is abnormal bone marrow signal, and it is hypointense in stir sequence. I want to drive your attention T2 hyperintense ödem-like signal intensity surrounding the hypointense lesion. This is important findings that suggest the high probability of the malignancy. If a hyperintense signal intensity surrounds the hypointense lesion in T2 weighted sequences, it suggests high probability of the malignancy. And there is a hyperintense ödem-like signal intensity surrounding the hypointense lesion. This is coronary plane, and this is a fat suppressed contrast enhanced T1 weighted sequence. Lesion enhanced peripherally from peripheral part to the central part, And in the posterior part, there is a soft tissue extension where I suspect from the lateral view. Here, there is a suspicious soft tissue extension in the posterior part of the lesion. It is a sclerotic lesion. And in sagittal plane, you can see the soft tissue extension. I said before, when a bone lesion extends into the soft tissue, it should be considered as malignant until proven otherwise. And this is three images. T2 hyperintense signal surrounding the hypointense lesion, which is one of the findings which suggests the high probability of the malignancy. The other one, this is axial plane. The other one, soft tissue extension of the lesion, suggests the malignant feature. It should be accepted as malignant until proven otherwise. This is axial plane T1 with the sequence. In axial plane, you can determine the compartmental speed of the bone tumors. You can evaluate the you can determine the local staging of the bone tumors in axial plane in MRI. And lesion extends into the mesenchymal bursa, into the soft tissue, and hyperintense ödem-like signal intensity surrounding the hypointense lesion, which suggests the high probability of the malignancy. And this is the X-ray image, and this is the MR image. X-ray image tells the nature of the lesion. It contains a ossified matrix, which suggests the osteogenic classification of the tumor. Dense and cloud-like ossification is present in X-ray, which suggests that this tumor belongs to osteogenic tumors. And the MRI findings suggest the malignancy of the malignancy feature of the lesion. And considering the radiological findings and patient age, radiological diagnosis suggests the diagnosis of the osteogenic sarcoma, and biopsy confirmed the diagnosis of the osteogenic sarcoma. Osteogenic sarcoma is a high-grade malignant tumor. It has high propensity of metastasis, and biopsy tract can be contaminated by the tumor cells. So, as treatment, first treatment should be neoadjuvant chemotherapy when the patient diagnosed with osteosarcoma. After neoadjuvant treatment, limb sparing surgery should be performed if possible. And in our case, firstly, neoadjuvant chemotherapy was given. After that, limb sparing surgery was performed, followed by total knee arthroplasty. This is the follow-up, one of the follow-up CT images. This is the showing total knee arthroplasty, and this is the coronal plane CT image showing the total knee arthroplasty. This is the resection site of the fibula, tibia, and the femur. And 10 months later, lung CT were taken, and in lung CT, there are several nodules which contain calcification here, Here's a lung nodule located in the right lung, apical lobe of the apical segment of the lower lobe, and there is a small nodules here. And as you all know, the lung metastasis of osteosarcoma may contain calcification. Calcification as occur in the primary tumor due to the osteoid projection. And this nodules is constant with a lung metastasis.
Indeed, that's a very specific sign to see the
Yes.
calcification in the lung. So you can always be sure it is some osteosarcoma metastasis. Do you also, if there's chondrosarcoma metastasis in the lung, I don't know how frequent this is, would you also expect calcifications in chondrosarcoma?
It is very lower when compared with the osteogenic sarcoma, because osteosarcoma has high propensity of metastasis, especially to the lungs, with 80%. At the time of diagnosis, in 15 to 20% of cases, lung metastasis can be present. This is the single most negative prognostic factor for the patient. When a lung metastasis present at the initial diagnosis, we can think the prognosis of the patient is poor. When not, we can think the prognosis is higher when compared with the lung metastasis present patient.
I see.
We interpreted this as constant with a lung metastasis and 4 months later. This is the thorax CT image taken 4 months later, and the number and the size of the metastasis were increased despite the aggressive treatment. There is a small metallic density. I think you can notice the metallic density. This is related with the cyberknife treatment. This is a gold material. For adjusting the cyberknife treatment. This is a marker. This is a marker for cyberknife treatment.
Oh, very interesting.
Size of the nodules were increased. Number of the nodules were increased, despite the aggressive treatment. Unfortunately, our patient passed away within 3 years after the initial diagnosis. Osteosarcoma, the most common primary malignant bone tumor found in adolescents, and it is a highly aggressive malignant bone tumor characterized by the production of the osteoid tissue. It has a significant risk of metastasis, which are the lungs are the most common site of metastasis with 80%, followed by the bone. In 15 to 20% of cases, pulmonary metastasis at the time of diagnosis may be present, which are the strongest negative prognostic factors. And these figures are taken from our archive. This is the classical case of the osteosarcoma. This patient, 21 years old male patient. Osteosarcoma mostly present in young adult and adolescent patient. Generally present with a pain and swelling. They have antalgic gait. Means difficulty in walking due to the pain. And 60% of the osteosarcoma lesion is seen around the knee joint. At the distal metaphysis of the femur, proximal metaphysis of the tibia. But the most common location is the distal metaphysis of the femur. It contains ossified matrix. It contains dense cloth-like ossified matrix. It causes aggressive type periosteal reaction, especially Codman triangle type periosteal reaction. And if I can magnify, and when we look from the open zoom, this can be seen on X-ray, but better seen on CT. It extends to the soft tissue. This hypointense area belongs to ossified area. This hypointense area belongs to ossified area. This is the Codman triangle type periosteal reaction. It shows the aggressive feature. And this is the ossified matrix. The X-ray tells this case is consistent with an osteogenic sarcoma, but the soft tissue extension is better evaluated by MRI. Bone matrix and the periosteal reaction better evaluated on CT when compared with the X-ray. And this is the classical example of the osteogenic sarcoma. It generally seen around the knee joint, mostly in the distal metaphysis of the femur. It causes aggressive type, Codman triangle type periosteal reaction. It extends into the soft tissue.
Very well described. Thank you very much. I have a question regarding the case. So here, this is again, if you look in the stream software, you see I'm sharing my screen, and you see you mentioned that we have this lesion, and then on the follow-up we did concentrate on this one. But how do you interpret this one? Is this a cortical defect? Is this an NOF, or what would you say is that?
It may be non-ossifying fibroma. It may be, but it may be bone island. I don't know, because as you mentioned before, non-ossified fibroma is seen in the cortex of the bone, and it looks like a bone island. It looks like a bone island or anastosis. And one of the participants asked
Okay, good. Okay, so I know you have a second case prepared.
Yes.
I'm curious to know about your second case, case number 3 for other participants.
Okay. I'm continuing with the second case.
Yes, please do it.
Yeah, okay. And my second case, 24 years old female patient, presented with a painful swelling at the base of her left thumb, persisting for 1 year. There was no history of trauma, and her labs were normal, no systemic illness. On physical examination, the mass was mobile and soft on physical examination. Also, she gave the history of biopsy, which was performed 3 months before at an outer center, which was reported as the benign soft tissue tumor. And 2 plain X-ray were taken. I will show now. And 2 plain X-ray. This is anterior posterior X-ray. This is the oblique X-ray. And again, bone alignment. The skeletal X-ray should be evaluated according to the ABCS rules. You should evaluate firstly alignment of the bone if there is fracture or dislocation. You should evaluate the bone structure if there is a abnormal density within the bone. You should evaluate the joint spaces if there is abnormality within the joint spaces. Also, you should evaluate the soft tissues. Always evaluate the systematical approach, the skeletal X-ray. When we evaluate this 2 X-ray of the patient on anterior posterior X-ray, there is a soft tissue swelling, and I am modifying this, and also I am sorry. And I think you can see the soft tissue swelling at the level of the first metacarpal bone, and also it contains dystrophic and coarse calcification within the lesion. Dystrophic and the coarse calcification. I want to draw your attention to the distal radial aspect of the first metacarpal cortex. Sorry. There is a suspicious periosteal reaction in the distal radial part of the first metacarpal bone. Yes. Can you see there is a subtle irregularity in the distal cortical part of the first metacarpal bone? It contains coarse and dystrophic calcification.
Yes.
It is located in the paraarticular soft tissue. Paraarticular soft tissue persisting for 1 year. MRI was recommended for this lesion because of the persistence of the soft tissue tumor for 1 year and suspicious findings on X-ray. But patient at first glance didn't accept the MRI. And based on the radiological findings, constrain the patient age and what is your diagnosis? Is it hemangioma? Is it extraskeletal chondrosarcoma? Is it synovial sarcoma? Is it soft tissue osteosarcoma? Or is it myosis ossificans? Yes, mostly answered. Most of the participants gave the correct answer.
Very good.
Yeah. And on X-ray, in osteosarcoma, as shown previous one, dense cloud-like ossified matrix in patient with osteosarcoma. The age group is constant, but the radiological appearance is not constant. In chondrosarcoma, rings and arcs type calcification seen in patient with chondrosarcoma, and the age group is a little bit older when compared with our patient, and the age of the patient and the radio X-ray classification pattern is not constant with the chondrosarcoma. In hemangioma, multiple phlebolyds, small, tiny calcification due to the small, tiny vascular calcification is seen. Multiple phlebolyds is seen in patients with hemangioma. X-ray appearance is not constant with the hemangioma. In myositis ossificans, you can see a circumferential calcification with a lucent center, which are not constant with the our case. And in synovial sarcoma, we can see coarse and irregular calcification. X-ray pattern suggests the diagnosis of synovial sarcoma, but I should see the MRI of the patient. And patient, I think 6 months later, came back to take the MRI. This is a coronary plane T180 sequence. This is a sequence coronary plane. As you see, there is a soft tissue tumor located at the level of the first metacarpal bone. And this is the subcutaneous fat tissue, hyperintense subcutaneous fat tissue in T180 sequence. And there is an obliteration of the subcutaneous fat tissue. This is tumor infiltration. This is constant with a tumor infiltration, and it extends into the joint space. It extends into the joint space. This is the normal bone marrow signal. This is the abnormal bone marrow signal. Abnormal bone marrow signal. I want to draw your attention the signal intensity in T180 sequences. This signal intensity, hypointense homogeneous signal intensity. that is isointense to the muscle tissue. When we see hypointense signal, homogeneous hypointense signal intensity within the bone, we should investigate this signal intensity because it may belong to infiltrative processes. It may belong to infiltrative processes. And in this patient, this abnormal bone marrow signal belongs to bone marrow infiltration. And this is the infiltration of the first metacarpophalangeal joints. This is the subcutaneous fat extension of the tumoral lesions. And this is the soft tissue tumor located at the level of the first metacarpal bone. And this is the sagittal plane, T1 weighted sequence sagittal plane, and this is the contrast enhanced fat suppressed sagittal plane. It enhanced diffusely, indicating the solid nature of the tumoral lesion. And the palpable mass is located at the dorsal part of the first metacarpal bone. This is the palpable mass, extends into the first metacarpophalangeal joints and infiltrating the bones adjacent to the joint. And there is a non-enhancing area which should be, which can be constant with necrotic areas, and also presence of necrosis within the tumor suggests the high grade of the tumor, probably high grade of the tumor. And this is heterogeneous diffuse enhancement of the tumoral infiltration. Palpable tumor is located in the dorsal part of the first metacarpal bone. This is the axial plane. This is the axial plane. And, this is fat suppressed T2 weighted axial plane.
So I think
this is a T1 weighted sequence axial plane, and there is a heterogeneous hyperintense signal of the lesion, heterogeneous hyperintense signal of the lesion, and hypointense signal in T1 weighted sequence. This is the tumor. This is the extension of the tumoral lesion to the first metacarpophalangeal joint. This is the tumoral tissue. This is the tumoral tissue. It elevates the extensor pollicis longus tendon. This is the flexor pollicis longus tendon, and it displaces the tendons. This is the normal subcutaneous fat tissue, but this is abnormal subcutaneous fat tissue. This is complete obturation of the subcutaneous fat tissue with the tumor. This is a heterogeneous enhancement. I want to draw your attention one finding again. This is a fat suppressed T2 weighted sequence. And triple signal intensity is present within the lesion. Triple signal intensity, which suggests also diagnosis of the synovial sarcoma. Because triple signal intensity is reported in 30 to 50% of the synovial sarcoma cases, which means this intermediate signal intensity constant with a solid feature. This hyperintense signal areas probably constant with a cystic or necrotic areas, and there is a hypointense area within the tumor, which is constant with calcification seen on X-ray, and hypointense area within the triple signal intensity belongs to calcification or fibrotic areas. And triple signal intensity is seen in T2 weighted sequences. This finding also suggests the probability of the synovial sarcoma.
Great
and
presentation,
biopsy.
really. Thank you. And it is, I see also the synovial sarcoma, I think, is sometimes difficult to diagnose, as here
Yes.
is a nice case where we have the joint close to the sarcoma, but I'm aware that this sarcoma sometimes appears quite away from joints. So it's called synovial sarcoma, but there's no joint close to it. Do you have seen cases like this as well?
Yes, it arises 10 centimeter apart from the joint space. It is named synovial, but it doesn't originate from the synovial tissue or joint spaces. it originates generally para-articular soft tissue. It may originate 10 centimeters away from the joint spaces. It is the most common soft tissue tumor that was diagnosed as incorrect diagnosis. That may get incorrect diagnosis. Sometimes it can be diagnosed as a ganglion cyst. Sometimes it can be diagnosed as hemangioma. This is the most common misdiagnosed soft tissue tumor.
Okay, that's interesting. I didn't know that.
It derives from undifferentiated mesenchymal cells capable of synovial-like differentiation. It doesn't originate, as you mentioned, it doesn't originate from the joint space. It generally originates from the para-articular soft tissue. Para-articular soft tissue. And biopsy was performed and confirmed this synovial sarcoma diagnosis. And amputation of the first metacarpal bone was performed to our patient. And 10 months later, despite the aggressive treatment, lung metastasis was developed in our patient. And also recurrent tumors was seen in the elbow area. In the elbow area, again, tumoral infiltration of the proximal radius. And these soft tissue recurrent tumors, unfortunately, this patient passed away within 2.5 or 3 years after the initial diagnosis, despite the aggressive treatment.
Okay, so you have really selected some cases with very aggressive malignant tumor growth.
Yes, I want to say also in radiography, only in 30% of the cases we can see the soft tissue calcification, dystrophic coarse soft tissue calcification. In 70% of cases, we cannot see anything in X-ray. So when we see para-articular dystrophic different appearance soft tissue calcification in a suitable age patient between the 15 and 40 years of age, you should add synovial sarcoma in your differential diagnosis list. But as I said, you cannot see anything in X-ray in 70% of the cases. It is mostly seen in 15 to 40 years of age, but it can be seen any age. In a few years ago, I saw a synovial sarcoma case in a 75 years old female patient.
Oh, that's interesting.
So
that's interesting.
It's all my cases.
So let us maybe finish with this case. I have one more from our side that I would like to show before we conclude. Here we have this case of a 62-year-old woman, and she is a known patient for renal cell carcinoma in good tumor control, and she has a good oncologic situation and now complains of knee pain after a hike at the weekend in the forest, and otherwise she's very healthy and also fit. So we analyze these X-ray images. We can see that there is no trauma, there's no fracture, but clearly we see also the joint space is good, so there's no osteoarthritis of severe form. But we see there is some lesion here in the distal femur. Even if we look at the soft tissues, we can see that there's this fatty stripe a little bit away from the bone, which is a sign that there's some soft tissue mass coming out of the bone, pushing away the muscle, keeping the fat more prominent. Also, we see this here in the femur. There are some calcifications here, but what is most striking is the destruction of the cortex. If you see here, the cortex is good to be seen like here, but here there's an abrupt defect, and we have no cortex here. So as I showed in the beginning with the Ludwig classification, I guess maybe it's between 1C and 2. We will try to check it. So we don't see the cortex, but we can maybe appreciate the border of the lesion over here, which makes it more like a 1C lesion. However, it's still a little bit ill-defined, and we have these classifications here in between. And we see it in the second plane as well. And also here we can see that there is destruction of the cortex and lucency in the cortex. There's also this long axis image. I don't know what else do we have here. Yeah, some more. And the question was which diagnosis is most probable. 13 people did take the time to answer. And the distribution is quite interesting. We have, of course, 90% voting for some malignant diagnosis. One person was in favor of enchondroma. And so if you have a case like this one with a history of a tumor, in this time a renal cell carcinoma, then of course after you have excluded trauma, which would be possible in this situation, of course then it would be most logical to think about a metastasis and not a primary bone tumor, because the most frequent malignant tumors in bone are metastases. So that's important. It's all good to know about bone tumors, osteosarcoma, chondrosarcoma, all this, but the most frequent ones are metastases. And so that is why the answer E is correct. And so enchondroma, I think, excludes itself as the cortex is destructed. We have some ossifications that could go with enchondroma, but the cortex is destroyed, and enchondroma would not do it. Enchondroma would maybe thinning, would do what we call scalloping, that is a thinned cortex, but we would expect more clean cortex here. So what we then can present is the MRI correlation. So you see here the T1 weighted image, and you can see that there are different parts in this lesion. We have, for instance, if you look here, we have one part that is really has a lot of signal loss, low signal intensity, and when you have some part with intermediate signal intensity, we can also go through the lesion and see the sclerotic part over here at the rim of that lesion. We can see it's relatively well defined in the bone, maybe with an exception here, and we have soft tissue extension outside of the cortex. So the cortex would be expected here. We have this soft tissue extension, and if you compare it with the X-ray, the increased fat lamella shows us that there's some soft tissue process pushing away the muscle, keeping space for the soft tissue, for the fat lamella here to be seen. Okay, so that is the T1 weighted image, nicely showing the lesion. Also, of course, if you have a T2 weighted MRI scan, that is, of course, giving a more high contrast between the lesion itself and the bone marrow. However, you need to have both types of sequences in order to come to conclusion. Also here, the calcification shows up a little bit more prominent in the fat-saturated T2 weighted lesion scan compared to here. Then, of course, we can see it in all the planes that we see. Also here, you see nicely that there is extension of the lesion down here. You would expect some fat here in between. And I think even after gadolinium, they checked it again. So it's quite an extensive MRI protocol. So this was an osteolytic metastasis from renal cell carcinoma. And this should be noted that especially in renal cell carcinoma, osteolytic metastases occur, and they are very typical, in fact, for renal cell carcinoma. They may evolve in any stage. Sometimes maybe even they are prior the diagnosis of the renal problem, because the kidney itself has no nerves, so there's no pain coming from the kidney. So you don't know if there's a tumor growing, only if there's the urine filtration diminished, if you have blood in the urine, or if you have a stop of the urine, then you can see it clinically. But usually renal cell carcinomas are most frequently incidental findings. So they might be quite large already when they are diagnosed, especially if they are diagnosed by a bone metastasis. So long bones are preferred by lytic metastases of the renal cell carcinomas, and usually they only occur solitary, meaning only one. And as our case also showed, they are eccentric usually, which means they are not in the center of the bone, but they are more on the lateral part of the bone. So that is something that is important, as this is something not so rare as a synovial sarcoma. I wanted to present also some more of the frequent lesions that are relevant for this topic. Would you like to comment something on this case, Özgür? Did something come to your mind?
Yes. If the patient has not a renal cell history, I can add the giant cell tumor to the first diagnosis because of the location of the lesion. It is generally located in this area. It is located eccentrically, giant cell tumor, and metaphysio-epiphyseal region. But the age group is a little bit younger than this age group. It is mostly seen at the age of 30s and 40s, giant cell tumor, but cortical destruction and is not constant with the giant cell tumor. But in giant cell tumor, generally seen as a pure lytic appearance, geographic lytic appearance. Sometimes it may contain calcification giant cell tumors, but as you mentioned, patient has a renal cell carcinoma, and this is interesting case.
Oh, okay.
Thanks.
So yes, so giant cell carcinoma may have a similar location. That's true. With a clear like a full destruction of the bone, also spongious bone, also full destruction of the cortex. And I personally didn't know that giant cell tumors might reveal calcifications. So that is a very good insight from you here today. Okay, so that's more or less, we have two more cases that we will present in a later stage. Case number 5 is not a bone tumor itself. It's a rare sclerotic bone lesion. It's called melorheostosis with a thick sclerosis in the bone and also outside the bone. So you can study this in after the show. Also, we have here some question, and if you answer it, there will be a learning text coming. And also our case number 6 is a case where we first had some problems with the questions that are now fixed. And this is the case of osteosarcoma. So you can also study this and compare X-ray with CT and MRI. And we present it later on in our social media presence. So for today, I'm very grateful to have you here. As you know, BerlinCaseViewer has some educational offering. We have the online academy with our cases that we are collecting in the field of pulmonary lesion. So we've collected like chest X-ray cases, some cardiac cases, which we are expanding in the end of the year. We have a lot of musculoskeletal cases, and then of course rheumatology is our strength. And we are so rheumatology, like half of our content is about rheumatology. So that is something I think unique, as you cannot learn it in this intense fashion in other educational offerings. And we also have nuclear medicine cases that we are recently bringing out together with Ziad Rishek from Jordan, and he's a very hardworking nuclear medicine physician, and is creating lectures and annotating cases. It's very interesting. And just to let you know how BerlinCaseViewer cases work when you are not having a live stream, when the experts are not there. Sometimes we have video-related lesions. We have videos as a connected to the cases, and also we have, for instance, case annotations. So we have here, this is a case of a patient with chronic knee pain. You see there are MRI scans with soft tissue lesions, intraosseous lesions, and you can look at these and try to interpret and learn. So a lot of things to look at. Then you answer the questions like you did today. You read and think on if one or more of this is correct. I forgot what's correct. I'm just clicking submit. And what then happens is that you are able to go through the case again, and then you can switch on these overlays. You see now you can look at the images again, and you have now drawings that we did in the MRI images. And I think that is something that that is very worthwhile to learn. So you can even if you split the screen, you can have these overlays on and off, and it's very good for beginners to learn, to know exactly where it is, not just a video, but truly in the image. So that's what I wanted to mention before we stop. So it was very nice that you showed up on this nice afternoon. It's quite warm weather, let's say hot weather here in Germany. I think Izmir is close to the Mediterranean Sea. It's maybe hot, but also due to the ocean, a very nice climate. And there are two comments which I will. There is some thanks coming. I think it's from Turkey.
Yes,
not sure. And we have also again. One of your friends or colleagues is thanking you, and also I'm very thankful for you, Özgür, that you showed up, because I think you have a very good knowledge on all things bone, and thank you for being here. Now my camera is off because it's too hot. So thank you, and see you next time. Bye bye.
Thank you, Dr. Kai, for inviting me. Thank you. Bye bye.